This is the Brave New Coin Crypto Conversation, hosted by Andy Pickering.
Hi everyone, Andy Pickering here. I'm your host and welcome to the Crypto Conversation, a Brave New Coin podcast where we talk to the people building the future in the Bitcoin, blockchain and cryptocurrency space. Hey team, we have a new sponsor here at the Crypto Conversation, BitGet, one of the world's leading copy trading cryptocurrency exchanges. Yes, indeed. What happens if you've got the funds to invest, but you don't have the time to keep track of the market? You still want to make smart money moves. What do you do? Well, copy trading is a popular choice for beginner traders. You can shorten your learning curve by uncovering tips and strategies from more experienced traders. BitGet's copy trading platform has over 80,000 elite traders to choose from and 380,000 followers just like yourself who are already using the BitGet copy trading platform as a potential passive income stream. All it takes is one click. You can subscribe to an elite, profitable strategist, set your limits, automate your orders, and monitor their trades. I've got some links in the show notes below. One link will take you through to the BitGet sign-up page, give you a VIP discount. So learn all about it for yourself thanks to BitGet. And now it is on with the show. My guest today is Pradeep Goel. Pradeep is the Chief Executive Officer at the Solve.Care Foundation. Now, Solve.Care is a blockchain platform for digital health networks, essentially healthcare on the blockchain. Heard that before. Very excited to learn all about this. Welcome to the show, Pradeep.
Thank you, Andy. It's a pleasure to be here.
A pleasure to have you here. Now, let's do what we do at the beginning of the show, Pradeep. It'd be great if you could please introduce yourself. I'd love to hear a little bit of your background and story in the lead up to you getting involved with Solve.Care.
Certainly, Andy. So I am a healthcare industry executive. I have spent over 30 years in various sides of healthcare. And I've had the fortune of really learning it from different dimensions as a public policy, public program policy, as healthcare IT, as a parent whose kids need care, sometimes more than usual, as a son whose parents need care as well. But really over the last 30 years in different roles in healthcare, as a CIO, as a CEO, as a COO of various health tech, insurance companies, and working on various public programs in the US, and also collaborating with a lot of clinical systems, I got to see healthcare from different dimensions. And after having built a lot of complex and large-scale systems in healthcare, Solve.Care came out of that whole experience, learning, and in the end, ultimately an epiphany that we got to do things differently if you want things to be different. Ergo, Solve.Care.
Yes, indeed. And I suppose it'd be quite interesting maybe just to set some wider context then, Pradeep, especially as it sounds like, as you've said, you've been involved in various parts of the health sector for some time. Now, it sounds like you're based in the US. And look, I'm not in the US, I'm in New Zealand. New Zealand, for good or bad, we have a reasonable health system here, which essentially is mostly funded by the state. I understand it's a little bit different in the US, and the US, it does kind of, from an outside perspective, it seems like it's quite a gnarly system and can be a little bit of a tricky one to navigate, especially for the less well off who don't really get the same level of healthcare as everyone else. Pradeep?
So, Andy, health systems from a visual optics perspective vary quite a bit. But when you analyze them, there are three fundamental issues that exist at a global level, and they repeat themselves over and over again, but in different combinations. So the three issues that I see in healthcare that exist in US and UK and New Zealand and Australia, just in different level of intensity, are: first, you have data silos, where the data related to a patient is in the control of different entities who don't have the ability or the desire to collaborate. Therefore, we are always looking to the quality of care is impeded by these segmentation and siloing of healthcare data that is needed for quality of care to be high. And that problem is universal. Somewhere it's more acute, somewhere it's less obvious, but it's always there. The second problem you have is care delivery silos, which is the more bigger problem and is less understood by a patient, but for someone who has looked at healthcare from the backstage to see how it actually works or doesn't work. The care delivery silos appear from simple fact of geography. You have urban areas with better quality and access of care and rural areas that often suffer from lack of specialty care. So there you have care delivery silos. Now, there are care delivery silos that can be organic, like geography, but there are also manufactured care delivery silos where insurance companies or hospitals or public health programs create delivery networks, which are by definition silos, and then require you to be in that network. And the quality of the network determines quality of your care. So these care delivery silos exist. Now, if the care delivery silo is so big that it encompasses the whole country, it doesn't feel like a silo, but it is, because you are still bound to a very finite delivery capacity and quality. And the third silo, for which US is particularly famous for, is payment silos. And there we get into this gnarly system of healthcare in the US, but they exist in other parts of the world as well. And those are as to who makes the payment ultimately seems to determine who gets care and how much care they get and when they get and if they get. So then you have and that's the most insidious silo of all, in my opinion. But these three silos exist in one shape or form. Now, it's true that in the US, the payment silos are very acute, and that's the one people celebrate and talk about the most as the problem. But the other two silos exist everywhere else. And the intersection of these three silos ultimately leads to either less efficient or more expensive or ultimately suboptimal care in practically every part of the world, including New Zealand. And what I came to realize in looking at healthcare, not just in the US, but my experience led me to many other parts of the world in working with governments and studying their health systems, is that we need to address and mitigate these silos in whatever shape or form they exist in each part of the world, because they do.
Yeah, thank you so much.
That's what Solve.Care is trying to do, to achieve, is to give a solution for healthcare in every part of the world to be less siloed, more open, and architected in a way that even if these silos do need to exist, they can interoperate with other delivery models. So you have better choice.
Yeah, got it. Thank you, Pradeep. And already I can start to understand a little bit about the potential of something like Solve.Care to begin to address some of these issues that you've very articulately identified. I think it'd be good then, Pradeep, perhaps if you could just share a little bit of the origin story, if you like, for Solve.Care. When did Solve.Care spring into life, if you like? When was it founded? What was the origin story, and how did you get involved?
Sure. So in many ways, Solve.Care emerged from my experience in trying to improve healthcare and being subjected to suboptimal healthcare, but also realizing that technology has advanced. But let's roll back. So I started in healthcare very early on. My first job out of college was in healthcare on the administrative side, learning how the insurance companies manage doctors' bills and how they decide how much to pay. And from there on, I moved into other areas of how these provider networks or delivery networks, the second silo I talked about, care delivery networks, are created and how they are managed and how you contract with doctors and why do you even contract? Why do you need a care network? Why can't you just let any doctor see any patient and just pay? But learned all those assumptions behind it. So from early 90s, all the way to 2004, I was on the payer administrative side, the insurance side, the public program administration side, meaning not so much delivering care, but rather paying for care. Then in my middle career, I started to work very heavily on public programs. Like in the US, we have a program for elderly called Medicare, and for the less fortunate, the Medicaid, for those who cannot afford to pay for care or even can afford to buy insurance. And then there's a third dimension of that called the employer-sponsored care, where majority of Americans get their care. So from that, I learned how do you think in the context of populations, groups, millions, hundreds of millions of people, and how do you design programs for that? And I saw a lot of inefficiencies on that side as well. So insurance side, I learned that this is the assumptions and the models of operation are not necessarily aligned to the patient. And then on the government side, I learned how constrained you can be and how your assumptions can lead to bad policy or at least bad outcomes. And then later on, I got involved with the implementation of Obamacare in different states. So started to work not just in the US, but also in other governments, and started to consult with other governments to see what they are trying to do. And they were asking us to come and help them. And from that, I learned that these problems are really either being replicated or they exist in, as I mentioned, in these three dimensions, regardless of whether you're the Middle East or whether you are India, China, or Australia, it doesn't matter. But they just, because these silos have different shapes and colors, people think, oh, my healthcare system is so different. But underneath the water, the iceberg looks pretty much the same. So from that, and because I'm a technologist and all throughout my life, I've been building systems to try to address problems. In about 2010 timeframe, I started to really ask the question when I was the CIO at a large insurance company, and starting to collaborate with other insurance company CIOs, chief information officers. Why are we doing this? Why are we repeating ourselves? And the other pattern I noticed in healthcare is that everyone declares their problem to be unique. Every hospital thinks they are unique. Every insurance company thinks they're unique. Every government thinks they're unique. But they actually repeat the same mistakes and they try to use the same solutions with slightly different veneer, so different skin. So 70–80% of the money in healthcare in terms of IT and administration and non-clinical cost that the humanity bears is repetitive. It's the same thing over and over again. It's just that the skin might look different. So there is a 20% difference and an 80% similarity in these icebergs. So I started to ask the question, what if we didn't spend all this money recreating what already is same or similar, and if we actually poured all the money into delivering better care? And in terms of mathematics, it struck me that about $7 to $8 trillion a year that humanity spends on healthcare, we literally are wasting 2–3 trillion of that in just being repetitive and in some ways just saying I'm different when you really aren't. So it's akin to everybody building their own car from scratch, when we could effectively build an assembly line and do have products that we can all rely upon, and we decide where we want to drive to. And you may go in a different direction than me, but we don't need to all reinvent this wheel over and over again. So I decided that for healthcare to be more open, more fair, and that's the other thing I noticed over the years, that your geography and your zip code often determines your outcomes in healthcare. If you happen to be in an urban, well-funded healthcare system, you're going to get much better care than if you're in a rural or in an unfortunate zip code. And the last thing that I noticed, geography, repetitive expense, similar problems, different skins. And the other thing that really struck me over the years is that 10 diseases, well-known diseases, are going to be the cause of death for more than one living human being on the planet. Out of 7+ billion people, more than 4 billion people will be afflicted by these 10 diseases, diabetes, hypertension, COPD, renal kidney failure, and so on. And these 10 diseases are well understood, and they have well-defined care models. And yet, for all the knowledge of the access from the internet and the knowledge we have as a humanity, there is huge disparity in how these 10 diseases are treated country to country, even within country, region to region. I come back to the zip code problem. If you're in a good zip code, you get better care. If you're in in an unfortunate zip code where it's a rural or it's not very economically advanced, or there's not enough physicians, you're going to get a very poor care, if any at all. So why is it that with all the quality of care, why is quality of care so different when we know how to take care of things, and this knowledge should be universally accessible and implemented? So these factors brought me to a very clear epiphany that for us to have a different outcome, we must do fundamentals differently. So you begin by asking, okay, what are the fundamentals of healthcare that are repetitive, that can be streamlined and standardized? And that's that 80% of the repetitive IT infrastructure that we reproduce over and over again. Standardization of access to the care models for these top 10 disease conditions, and for allowing a global open architecture where every health system can at least standardize on this repetitive, wasteful, and inconsistent flow of information. If we do that, then majority of the money that today does not go towards healthcare and actual care delivery could then flow into better drugs, better care, more physicians, better payment models, more patient engagement, and that would make all the difference. Basically, we eliminate the waste and redirect that money towards serving humanity. And you do that in a very clear way. Information access, care models, open care delivery networks, and allow for a much more efficient payment models to be built on a open architecture platform. And suddenly we are serving humanity much better. So that's the whole journey, my 30 plus years of thinking, looking, observing, making mistakes and learning, and saying, my gosh, these are so obvious patterns. And yet we allow these patterns to persist to the disadvantage of humanity. So when are we going to fix these patterns before we keep putting the, if you will, a Band-Aid on the disease instead of addressing the root cause? So I come back to those three silos I mentioned at the beginning, plus the disparity in care based on your zip code, regardless of the fact that we know how care should be delivered for these very prominent and prevalent diseases. And those four revelations in my head led to me saying, but there is a solution here, regardless of how complex healthcare is. And that solution is what Solve.Care is bringing to the market.
Okay, very, very nicely said again, Pradeep. And I can see, and look, listeners, the website is Solve.Care to learn all about the Solve.Care platform, and also Solve.Foundation, the other website. And you can see that there's a nicely designed ecosystem here around the Solve.Care platform, or the Solve.Care ecosystem, Pradeep. There's the Care Wallet, the Solve currency, the Care protocol, the Care Vault, the Care Ledger. So you can see, obviously, all the different components of I suppose, a blockchain ecosystem that is designed to essentially bring all sorts of efficiencies to healthcare, and of course, data sovereignty, very important for individual health data. But I suppose, Pradeep, the hardest part, of course, is getting people on board, or getting regulatory clarity, all these kinds of things. So I suppose that the next part of the equation is, where are you at in terms of that, I suppose, journey to getting different health organizations and platforms on board, even at a kind of a trial stage? Where are you at in terms of that journey?
Yes, you're absolutely right. I mean, the adoption for a platform like ours will come in waves, and it builds layer upon layer. And it is it has to be, by definition, a complete platform that can serve both an institutional audience and a consumer audience.
Yes.
And to achieve that, as you mentioned, Andy, just now, we have very well-defined application stack which is built on blockchain, but it really starts with the basic question: how will a consumer or an institution experience the platform? So that is defined by the Care Wallet. It's a standardized application that lets you access any transactional data or relationship that has been configured on our platform. So that's a uniform way to experience care. Now, within the Care Wallet, you have apps called Care Cards, which are going to be different based on needs. So based on who I am and what my needs are and who I'm transacting with on the platform, I will get different set of cards. And these Care Cards are decentralized apps, but they live and function within my wallet and your wallet. So I can send you a card and request an appointment. You can respond back with a Care Card, giving me an appointment and sending me a deposit request or a bill for payment. And I can send you with a response card, payment tokens, and confirm that here are my records or my symptoms. And this transaction can go back and forth between us till I have received the care from you, Andy, and you are my doctor and I'm a patient. But this relationship can be any to any. You could be in Australia, I could, or New Zealand, I could be in the US. But as long as these two wallets connect with each other and establish a relationship, then you can transact. And no one else can have any access to what we are transacting with each other, because we are in a peer-to-peer communication on blockchain, and there is no way for Solve.Care or anybody else to interfere in this transaction. Now, there are a lot of rules that go into that. When a relationship is created between patient and doctor, you have to have certain rules governing. If you are in if we are in the same country, we might have one set of rules. If we are in different country, we'll have different set of rules apply to you and I. So we allow on the platform to define these relationship models, and those are done in the protocol, the Care protocol. So this allows for compliance and security and privacy and preservation of rights, because healthcare ultimately is about relationship-driven and clearly defined roles and relationships between parties. And healthcare gets very complex very quickly. You might have a patient-doctor relationship, nobody else is involved, but you might have a patient-doctor specialty relationships, and so on. So we call them AB, ABC, ABCD, ABCDE relationships, where you can get more and more complex care coordination and payment coordination and benefit coordination problem by having more parties involved, but doesn't matter. The platform lets you define each relationship independently and then collectively. So by building this full stack platform where blockchain enforces the rights and the privacy and the rules of relationship and tracks consent of both parties consenting to abide to those relationship rules, gives us a global compliance framework, right? But it also gives us a lot of use cases. So if you are an insurance company, you can build a solution on our platform. We call these solutions care networks. And you can build a care network for all your policyholders, people who bought insurance from you. And you can coordinate with them benefits, plan, premium, payments, whatever. But if you're a hospital, you can use the exact same platform, the exact same Care Wallet, and you can launch different relationships and different cards to traverse those relationships. And here I might be looking at pre-admission consent and post-discharge care follow-up and prescription and exchange of medical records, or the ability for you to come back in for a checkup or a reminder that you need to do certain things. So whether it's clinical care or it's admission and discharge, or it's coordination of care with third parties like labs and pharmacies, hospital's network is going to look different. But underneath the water is just another set of relationships, right? And the same cards configured differently can flow between different relationships. So you have the same platform serving practically every complex part of healthcare. And let's take the third example. Let's say you're a pharmaceutical company and you want to conduct a trial. Well, now you have a trial coordinator. You have the private investigators, the ones who analyze the trial data. You have the FDA or equivalent of that. You have the patient. You have the lab that might be collecting specimens. So you have this different ecosystem. But in the end, if you think about it, these are just different relationships with different actors on the side, or two sides of the relationship, and they have slightly different rules. And you can configure different care cards to traverse these different A/B relationships. But you can run a clinical trial on the platform a lot more efficiently than you could do with any Web2 centralized model, because it suffers from a lot of fundamental limitations that we talked about earlier. So the point of our platform and its adoption curve is that we allow the client to configure whatever relationship model will serve their stakeholders the best. And you can build as simple as an A/B relationship model, or an ABC, or an ABCDE, and as far as you need to go. And we help our clients think through and analyze all that, which I can touch upon later. So having said that, coming back to your question of how adoption is happening, we are seeing adoption among health delivery systems, people who deliver care to patients like you and I. We are seeing adoption by health management organizations like insurance companies and public health programs who need to manage the delivery and payment of care. And then we are also seeing adoption by or sponsored by pharmaceutical and life sciences companies who want to run a more efficient and engaging discovery, research, and trial programs. But the most exciting part is that we are seeing clinicians adopt the platform to deliver better care directly to their patients, whether it's a small physician with, husband-wife team in a rural village with, 2,000 patients, or it's a, large practice in New York City with 150 doctors of all specialties working together in a large clinic, serving 100,000 patients. Doesn't matter. What we have found is that physicians love the idea of being able to configure the relationship with their patient based on disease condition or based on their need, and quickly author these cards to drive better care between them and the patients. So we are really looking at it as, as a platform that can serve every healthcare entity, whether it's administrative, clinical, or financial, and at all scale, individual physician all the way to giant health systems. Like in the US, we have big names like Mayo and Hopkins and Kaiser and so on. And in the UK, you have the National Health Service, and most countries have a mix of, public and private clinical care delivery systems. So we find ourselves to be pretty relevant in almost every part of the world. In fact, we have not yet uncovered an exception where our platform cannot serve both the existing care delivery systems as well as help new ones emerge. So the adoption is growing, and it's growing across all dimensions of healthcare.
Well, I'm pleased to hear that, Pradeep, and I hope that does continue. And, solutions such as Solve.Care are badly needed around the world, obviously in the Western countries that we've talked about, but probably even more so in poorer countries or the developing parts of the world where the health infrastructure is in need of investment, really. But, there's one thing that does tend to improve health outcomes over time. I'm sure you'll agree, Pradeep, and that is simply the advance in technology, specifically the advance in medical technology. But you described yourself as a technologist, Pradeep, so I'm sure you are well aware of the revolution that is now underway in terms of generative AI. And I'm just curious as to your thoughts on how the rise of these new AI platforms might start to play a role in taking healthcare up a step all around the world, because it seems that if you can combine access to individuals private data, perhaps on a blockchain platform such as Solve.Care, with health GPT or something like that. It gives people much more wider access, I think, to medical knowledge that they might not otherwise be able to access. Do you think?
Yeah, absolutely, Andy. I think there is a lot of exciting technological developments. Particularly, we look at AI. We also look at the growth in high-quality diagnostic devices that patients can have at home, as opposed to having to go to a large institution and with a greater cost and a greater effort. So you got medical device evolution. You have artificial intelligence, which can supplement, at least do risk factor analysis and supplement diagnosis, and support physicians in discovering the root cause. You have the advent of blockchain, which gives us a open architecture for transaction capability that does not necessarily require parties to reveal their identity or reveal excessive amount of identity. So you can now transact with parties on a blockchain that are not in your geography. They can be anywhere, and you don't need to necessarily disclose the name of your children to get care, because it's not relevant identification. You have the advent of tokens like Solve.Care, Solve token, and there are others which can be programmed to make payments easier, both inside a care in a payments network, as well as across national and international boundaries. And you have, of course, mobile computing, which we have all come to take for granted now, but it's only about 20 years old, where you have a growing access to mobile computing in your hand, and access to a user experience in your hand that does not bind you to a computer or to a location. So these are all coming together, and we see each of these technologies playing an important role. However, in healthcare, healthcare is not transactional. Healthcare tends to be an episode. Okay, so when you have a health episode, it has many transactions in it and many parties in it. So healthcare, by definition, is very different than e-commerce, where you buy and sell. I purchase, I get my goods, I go home, transaction is complete. In healthcare, it's episodic. So because of that, you need to maintain a complete journey map for how this episode needs to flow, and who needs to come in at what point to do what. So there's always a coordination problem in healthcare. Even the simplest healthcare system to the most complex healthcare system, you always have a coordination issue. So in that regard, you need something more than these tools, these technologies that we're talking about need to make an episode work better. So if you now, let's take the example of AI. AI might give me as a patient better understanding of what might be ailing me, or even might do a self-diagnosis. But for me to get proper treatment for that, I'm going to need to collaborate with a physician or a lab or a pharmacy, and I'm going to need to have a post-interaction continuity of care, like am I following my prescription? So this whole episode needs to be managed, and that requires an episode management framework. And that's what Solve.Care is doing. It's building this open architecture fabric on which you can manage any episode, and you can inject into this episode the right technology, be it home diagnostic, where you can just do an EKG right sitting at your table in the office or at home, and have that data feed into in a proper contextual way for the physician to analyze either before or after consultation, or before and during consultation, leading to an outcome or a diagnosis and a treatment plan that you need to execute with the help of your family. So all the technologies that we are talking about, and they are exciting indeed in isolation, they all need to somehow fit an episode management model. And that's why we designed healthcare relationship management as the underpinning of Solve.Care platform. And that's why we just recently released Care Chain as this open layer 2 chain, purpose-built for managing competencies, roles, relationships, and episodes of healthcare. And that's why you need something that allows the injection of technology and digital data and automation and data sharing and identity management and a configurable user experience. You need the whole thing, which is what the Solve.Care platform is, as you mentioned earlier: wallet, cards, protocol, vault, ledger, nodes. All of these pieces need to be in place for something like AI to be introduced into this episode at the right time, if that makes any sense, right? So we are very excited about what ChatGPT as a language model can do in terms of assembling the data that already exists in the human consciousness and in our archives. And it goes back to my point that the top 10 disease conditions that will affect more than 4 billion people in the coming years, and either we will or we will know someone who will suffer and pass from these diseases. Health GPT type models can bring uniformity of knowledge and uniformity of care models. But we still then will need a way to actually exercise that care model for you or for me or for my mom or for my kids. So we need this management system, the way Solve.Care is envisioned, and of course others will do it differently, but the principle is the same. You got to have a health relationship and health episode management architecture that everybody can use and configure to their need, and the ability to extend this episode management capability with technologies like AI and home clinical devices. But I will give you a very specific example to illustrate what you're saying is so true. We have recently been approached by a company, and we get lots of excellent ideas and innovators saying, I want to plug in my technology into the care platform. But one of them is essentially an AI-based risk assessment tool where I can take a 30-second selfie video, and it analyzes that video and is able to determine from the video my heart rate, my blood pressure, scan my retina for certain indicators of disease. And it actually generates more than a dozen key vital health indicators that would take me, give or take, 2 to 3 days worth of tests and running around and weeks of waiting to collect and assemble all that information. And it generates that data with a reasonable accuracy. While it is not hospital grade accuracy, it's sufficient for me to detect clear outliers of my health, which will then cause me to go see the doctor. So it's not a diagnostic tool, it's a risk assessment tool, which says to me, Pradeep, something is off. I see a potential for a irregular heartbeat. Over the last 10 readings we have done over the last 10 days, you seem to have a pattern, and we think you should go see a cardiologist. Now, that early detection, it may be a false positive, but I would rather have a false positive than to have zero awareness that I have, no risk. So in that regard, AI is already starting to be used in ways that aids me, the patient, to become more aware and engaged in my own health. But to actually manage that episode, you need a platform like Solve.Care. So we're very excited about the confluence of technologies in patient engagement and in supporting the physician, coupled with our ability to manage healthcare episodes and healthcare relationships properly. We think that healthcare will change faster in the next 10 years than it has changed in the last 30 years.
Yeah, that makes perfect sense to me, Pradeep. And I think you're exactly right in that, AI is more at the level of perhaps complementing physicians or doctors at the moment, but also in the same way that ecosystems like Solve.Care exist to increase efficiencies is one way of describing them, but also AI essentially is more efficient than humans. Human doctors, of course, they do their best, but if you're a doctor that's under pressure and you're seeing 15 patients a day, things can go wrong, and I can just see how AI in partnership with something like Solve.Care will do exactly what you've just suggested. 30 years of progress within the next 10 years. Well, as we start to finish off, Pradeep, closing thoughts. What gives you hope for the future then? I guess you've just said that, we're going to see all this change ahead, which that must give you hope that we're on the right path.
Yes, I think that you said a couple of things that I want to concur with and reiterate. The first is that there is a lot of change in the offering. Healthcare has a pent-up demand for innovation and for transformation, but it has been stymied by those silos that have been so entrenched. The care delivery silos, the data silos that are getting worse, not better, and then you have the payment silos that emerged out of need to manage cost of care from a societal perspective. So those silos have become so entrenched, and now the advent of technologies like blockchain and platforms like Solve.Care are really at the cusp of offering an alternative way to do. We are already offering an alternative way to run healthcare in a non-siloed way, and governments and institutions are responding, but they know that silos aren't serving anybody, including themselves. So that's one thing that's very interesting, because if those silos continue to exist, and we're working hard to bring those walls down, all the other technological advances will not produce the value they should produce, because we could have the best clinical care models or home diagnostics or AI-based self-assessment, but if you can't get to care after you've identified the risk, well, it didn't do much. It just told me that I have a problem, but I can find somebody to help me solve it. So the healthcare's impact on humanity and all the advancements in technology we are seeing, for those to be fully realized, we have to address the care, payment, and data silo. Without that, we keep coming back to, well, healthcare isn't as effective as it should be. So this is one thing that I'm very excited about, and why we chose to focus on administering the healthcare episode better, defining relationships, and offering advances like care chain, where you can effectively build your entire own DApp system, write your own rules, and create a really powerful health system that today could not exist, because Web 2 would not let you do that. It's just not architected to achieve that goal. So that's one thing I'm excited about. The second thing I'm excited about is the advent of new technologies that empower the patient. The devices, the home devices, the access to telehealth, and ability to speak to qualified physicians no matter where I am, and not have to make a journey to a health delivery system, but rather to have healthcare come to me. So that means accessibility is improving. The third part that is really important is awareness. Tools like my ability to do an EKG at home, my ability to use AI to determine if, given my family history of diabetes, what's the probability I'm going to get one, and what are my choices to deal with it. So I can actually be an engaged consumer of healthcare, not a passive beneficiary of care who arrives in an ambulance and doctors do something to me. I want to be actually engaged in managing my care, and so do you, and so would I want my mom. So awareness through tools like AI and home diagnostics and risk assessment tools and things like Fitbit and Apple Watch are contributing to that awareness, but they're not really the solution, because they are creating non-contextual data, and what we need is actually episode management, which brings me back to point number one, that it's a triangle: awareness, ability, and administration, the ability to actually get and manage care. When we bring those three things around the patient, when we draw this triangle around the patient, we get a very different healthcare system than we have today, and regulation will evolve to make this triangle work better and better. But for the first time, I think in human history, this triangle is possible and is actually there. Now it's up to companies like Solve.Care to make this triangle work well. This triangle around the patient of awareness, access, and administration, effective administration. And that leads to, I think, a much less degree of suffering at a lower cost, and a much easier and a much more friendlier user experience. So I'm optimistic. It's not an easy road, but I think it's a road more possible today than it has ever been in human history.
Fantastic. Wonderfully said, Pradeep. Very much enjoyed that. It's been superb talking to you today. Just to finish off, please tell the people where they can go really to learn all about what you and the team at Solve.Care and the Solve Foundation are building. And if you've got a Twitter profile, please shout that out, or LinkedIn, or wherever else you like to hang out online.
Yes, absolutely. So we have a very active global community. We have a Solve.Care channel on Telegram. We have a LinkedIn profile, mine and Pradeep.Goel at Solve.Care, and of course, Solve.Care's own LinkedIn profile, which is very active. We have Twitter feed and Facebook, and our website, Solve.Care. Easiest way to learn about us is join the Telegram community, or to send us an email at info@solve.care, or reach out to me on LinkedIn. But we have a very big global community of physicians and clinicians and patients and people with chronic diseases and parents of kids with diseases. So this is a very active community on Telegram. And of course, we have a very active blockchain community. So I would say there are multiple ways to get out to us, but feel free to use whichever channel works the best for you as an audience. And I'm always available. You can connect with me on LinkedIn. You can also reach out to me on email at info@solve.care, and it gets directed to me. So we look forward to hearing from healthcare institutions, clinicians, patients, parents, pharmaceutical companies, public health administrators, insurance companies. We really have a framework that you will find useful for your healthcare needs. And if nothing else, you want to simply create a collaborative healthcare network for people, like-minded people, and collaborate with them on managing certain disease conditions, you can do that too. So we have a platform that practically serves every healthcare stakeholder, including the patient. So reach out to us and we will be happy to help.
Awesome. Thank you so much, Pradeep. All the best, and bye for now.
Thank you, Andy.
Look, we'd all like to say we're pro traders, but the reality is we're probably not. But with BitGet, you don't have to be. Why? Because BitGet is the world's largest copy trading exchange. Instead of you muddling through it on your own, feel confident. BitGet allows you to automatically copy trade from over 80,000 elite traders, with 24/7 support on our secure copy trading platform. Start following expert traders on bitget.com. Check for details in the show notes and join BitGet today.
All right, there you go. That was Pradeep Goel from Solve.Care Foundation. Interesting one. Interesting show. Thank you, Pradeep. Very much enjoyed, a deep dive really into how blockchain protocols can essentially, drive those efficiencies and connect all the data silos really. And I think he's right, once we can integrate AI as well, we really are going to see unbelievable innovation and progress happen in the decade ahead. Exciting times to be alive, people. All right, well, thank you for listening. That is the end of another episode. Please make sure you are subscribed to the Crypto Conversation in whatever podcast app you are using. And that is today's show. This was the Crypto Conversation for Brave New Coin. See you.